Thank you, Dr. Balakumari. Dr. Barney, you've already been introduced. Please come to the dais. So, in this post-lunch session, I'm happy that the hall is full and so many people interested in GDM. We have got two very good speakers and two good chairpersons to handle the session. What I'm going to do is, since I'm the first speaker, I'll give you an overview about gestational diabetes, but also speak about some of the newer aspects of GDM which are emerging today. So to start at the definition, is a very old definition. So GDM, or gestational diabetes mellitus, is defined as glucose intolerance of any severity with onset of first recognition during pregnancy. So people may say, what if they had diabetes earlier and then it was only picked up during the pregnancy? Well, technically it's still gestational diabetes, but then there are methods to prove that. If you do a HbA1c and you find it's high, then we know that they've had it earlier. Earlier they used to say that it has to revert back to normal after the delivery. That was later dispensed with. So I'm going to just briefly talk about the first two trials, because they are a little older trials, especially the first one. And then I'll spend a little bit more time on the toboggan trial. So we have actually done 4 major trials on GDM. All of them are international trials: the WINGS project, the STRIDE project, the toboggan trial, and the LIVING trial. So the WINGS trial was started several years ago. This was completely funded by the International Diabetes Federation, who got support from the Abbott Fund, but we didn't get any direct support from the Abbott Fund. It's an IDF project, which they gave it to us. And the idea behind this is they wanted us to come up with ideas to improve the care of women with GDM. So they wanted us to find out about the status of GDM, what can be done to prepare materials for the patients, for community, for doctors, and so on and so forth. So it had many aims. And just one thing I wanted to tell you, Dr. Umaram was supposed to have been here for the session, but she had to go for another meeting out of town, so she's not here. So she is the first author of this paper. And this was published in the Journal of Obstetrics and Gynecology Research. And what we showed here was that by developing a model of care, we developed not a very sophisticated model of care which cannot be used anywhere, but can be used even in rural areas and so on. So using this model of care, if we treat these women according to the model of care, what will there still be a difference between GDM women and non-GDM women? You can read the paper, but the short answer to that is, if you follow all the rules of the model of care, diagnosing them early, treating them early, the proper follow-up, and so on, you get results which are comparable. There's no difference between the women with GDM and the women without GDM, because we had both in the trial. So that is a very good outcome of this particular trial. The other thing that came out of the WINGS trial was, from the beginning, when we started the WINGS trial, we had only one aim. Women don't come back for follow-up after the pregnancy. All over the world, it's the same. The moment they deliver, until they deliver, if you tell them to check blood sugar 3 times a day, they'll check 10 times a day. But the moment they deliver, they won't check even once a day. They'll just stop giving. Now my child is my priority. Mother is like that, and so you can't blame the mother. But how do you improve this? Then they'll develop diabetes and come severe diabetes later, and we've lost a lot of time. So how do we do that? So for WINGS, we went on saying, every time they came, come back, come back, come back, come back, come back. It's almost like brainwashing them to say, at least that will it work. It actually worked. Now, as you can see, that 6 weeks after first of all, we had a 96% follow-up after the delivery for postpartum follow-up, which is a kind of world record which we set. Of course, this is not a real-life situation. It's a trial, and with a lot of effort again and again and again and again, but at least we proved it's possible. If you do that kind of thing, women may come back, but it's not possible in real life. Okay, but the other thing that we found was the conversion to dysglycemia. We called it dysglycemia because pre-diabetes and diabetes is included in that. Within 6 to 12 weeks, already 15% of women have converted to diabetes. See how quickly they're converting. This doesn't happen in the West. It takes much longer. And by the end of 1 year, 38% had converted to diabetes. So the conversion doesn't take 4 years, 5 years. Very rapidly they are converting. And these are women who were normal immediately after. And then 6 weeks later and 1 year later, they're converting very fast. So that's the thing that I want to talk about that. Now let me switch to the next topic which is close to my heart, and that is the subject of early GDM. Many of you may not know what early GDM is because it's a new concept. Only last 1 or 2 years this has been coming. Traditionally, when we talk about GDM, what the traditional thinking is, the baby has to grow, and then insulin resistance of pregnancy has to come in. Then the beta cells have to fail, and then only you will get diabetes. And that's the traditional thinking, and that's partly right. But then, when starting to screen women in the first trimester, we not only pick up women who had pre-existing diabetes, their A1C is high, sugars are very high, then they have pre-diabetes, diabetes. But there are another set of women who had milder glucose intolerance. They're not diabetic, they're not pre-diabetic, but they're not normal also, okay? And so that is what is called as early GDM. That means you're diagnosing in the first trimester, something completely new. So now based on that, because in the toboggan study we used 20 weeks as a cut point to diagnose early GDM. So if GDM is diagnosed before 20 weeks, called as early GDM, 20 to 28 weeks or later we call it as late GDM. How do you diagnose early GDM? We still don't have proper criteria which all over the world they have accepted. In 2010, after the HAPO study, the IADPSG suggested that if the fasting plasma glucose is between 92 to 126, below 92 is normal, 92 to 125 is GDM according to them, and 126 and above is diabetes. Now this was heavily criticized because 92 seemed to be too low. A lot of normal women can have that. So then they withdrew it, saying that, oh, it's too low, and they didn't know what to do till toboggan came, and I'll show you what happened. Now, Wesley Hannah, who is a PhD student, when she joined us for PhD, I told her to take the subject of early GDM. So one of the first things she did was to do a proper systematic review. It was published in 2022. So 3 years have passed, and I know that many others like Dr. Harita Sagili here are doing a lot of work on early GDM in JIPMER and other places. But this is a review if you want to read. I'm not going to go to the details of that because it's already published. Now, around that time, we took up our next study. This is an Indo-UK study funded by UK. And we didn't set out to diagnose early GDM at all. The question we are asking is different. Okay, significant number of women are going to develop GDM. In India, it's 25-30% of all pregnant women. How can you identify them in the first trimester? Can you say, if you follow this and if you do this, do that, cut point, some criteria, can you say these are the women who are going to get GDM? Now, until you test them, you don't know what to do. So that was, we want to develop a risk score. It's a large study, 3,000 women whom we screened. Lots of sites were here, including JIPMER and Dr. Umaram's clinic and many others, including Hyderabad and so on. What we did was, first of all, those who had diabetes in pregnancy, that is, if your fasting was more than 126 or HbA1c is high, we excluded them. The others, what we did was, we did a fasting glucose, and if it's between 92, because there's no other criteria is available at the time, so we used this 92 to 125, we called them as early GDM. And then if the fasting was less than 92, then as recommended in the 24th to 28th week of pregnancy, we did an OGTT and then picked up GDM, and we called them as late GDM. So now you've got 3 groups. You've got a normal glucose tolerance group, you've got a conventional GDM or late GDM group, and you've got an early GDM group. Now we just submitted this for publication, it's under evaluation. So we compared the normal glucose tolerance women with the late GDM women, and what we found was that if you look at this, is too light. So if you look at the early GDM group, they were slightly worse off than the late GDM group. Look at all the values. Booking weight, 64 kilos compared to 61 kilos. BMI, 26 compared to 25. Waist, 89 compared to 87. Glucose, 98 compared to 90. HbA1c, 5.3 compared to 5.2. I want to point out this because the moment we talk about early GDM, people will say, oh, but that's diabetes. It was not diagnosed before. It's not diabetes. It's 5.3. At 5.3, you don't get diabetes. Okay? So this is early GDM. Okay? And so generally, we felt that these late GDM women were a little milder, or the early GDM women were a little more severe than the late GDM. And that's exactly what in subsequent studies from JIPMER, they are showing the same thing. What are the risk factors associated with early GDM? 3 things came out: BMI, HbA1c, and history of GDM in previous pregnancy. For late GDM, family history of diabetes came out, whereas here, earlier history of GDM came out as being significant. So we are able to actually separate out the early GDM and late GDM. We still don't know whether there is overlap, how much of it. We are still now doing genomic studies and other studies to show whether they are two different studies. Maybe next year I can present some of the details to you. Now the next controversy was, okay, what do you do with them? You diagnose early GDM. Where is the proof that treating them is good? Suppose treating them is bad? How do you know? So you have to do a proper study to show that it is safe and it is effective. Couple of small studies were done, 30 people, 40 people, didn't show any significant result. They were underpowered, so they didn't do. So then we took up what is called as the toboggan study. This was initiated by Dr. David Simmons in Sydney, and toboggan stands for Treatment of Booking Gestational Diabetes, the first multi-center, multi-country RCT of early GDM. So we had to diagnose early GDM, treat one group, don't treat one group. You will say, if you don't treat, isn't it unethical? We don't know whether treatment is good or bad. So till a study is over, it is ethical. Once a study shows something, then you can decide whether it's ethical or not. In future studies, you cannot do. At the time of toboggan, there is no such evidence. So we had to do that. So what we did was, this is published in New England Journal of Medicine, by the way. And in a way, this is changing the way GDM is being diagnosed and treated all over the world. So we had 800 women with early GDM. 400 of them we treated, we called them as intervention group. 400 of them we didn't treat, control group. Then we had a decoy group, I won't go into that. And we had 2,400 women who were normal. They did not have GDM at all. So now we have these three groups to compare. So we also know whether treatment is going to be helpful, not helpful, side effects, everything we can find out. In short, what we found was that it was effective and it was safe. So the primary, composite primary outcome was preterm birth, birth weight, birth trauma, respiratory distress, and so on, shoulder dystocia, was significantly lower in the intervention group compared to the control group, and this was statistically significant. The other two things, we wanted to see whether they'll become lean or thin or all that did not occur, and therefore it was a positive study. And from there, the value of treating early GDM was established. Now we revisited, you remember I told you that 92 was criticized very badly. So we had an opportunity here to look at who actually benefited. So we divided our group of GDM, the early GDM, into two. One who had very mild, we called it low band GDM. Look at the fastings, only 92 to 94, very mild. Purposely we did that. Then we had those who had 1 hour between 180 to 190 and 2 hours between 153 to 161. So it's just mild diabetes. The other is called high band, where fasting itself is 95 to 109. Now in GDM, in toboggan, we didn't go above 110. We didn't go up to 125. The reason is they'll say that is pre-diabetes. That is not GDM. Up to 109 is not even pre-diabetes. So therefore, people will accept it's GDM. Okay? And similarly, we had a 1 hour and 2 hour value, which is a little higher. You don't have to remember all these values. Okay. To cut a long story short, the higher the glycemic band, which means if you had higher glucose levels, they did better. They improved much better. It's not that the lower glycemic band did not do well. You can see they're on the other side of improvement only, but it didn't reach statistical significance. Once it doesn't reach statistical significance, there's no point in treating them. So 92 to 94, you should not treat. That's a lesson that we learned. 95 onwards, clear improvement. We also looked at, remember I said it's below 20 weeks. So we said, what if they're diagnosed before 14 weeks? And what if they're diagnosed between 14 weeks to 20 weeks? Does it make a difference? The earlier they get it, of course everybody benefited, but the earlier you're diagnosed, suppose you're diagnosed at 10 weeks, 12 weeks, they did better. Okay? So the moral of the story is very clear. First, there is beneficial effect in treatment, no side effects, and the results were more if you have more severe glucose levels and the earlier you get it in pregnancy. So those messages are very strong and clear. Nobody can contest that. About 10 to 15 other papers we have published from toboggan in the last 1 year, all in top journals. One of them was cost effectiveness. So one of the things which is asked is it cost effective to do that? Already you've got so many GDM. Now we are adding early GDM. Is it cost effective or are you simply adding to the cost to the nation? In this paper we showed, it did an economic evaluation and we showed it's actually cost effective. Because you end up in NICU and you add all the side effects, that's actually costlier. And most of them need only diet and exercise. They don't even need medication. Just ask them to cut off sugar and do a little walking and they're fine. So it's cost effective to do that. We also looked at how many develop postpartum dysglycemia. So how many develop diabetes. I'm not presenting all the results, about 15 studies are there. But to cut a long story short, again, compared to the late GDM, the early GDM seemed to be converting faster to diabetes. Now comes the $1 million question. What has all this to do with us? There's an Australian study, and what is to do with us? Maybe in Australia it's relevant. Well, for the first time, Indians were included from Chennai and other places, and they had a large South Asian component in Australia itself. Plus we had Southeast Asian, then we had Middle Eastern, then we had Europeans, then we had everyone, every race you can think of, including the Aboriginal populations we had. Now look at the prevalence of eGDM, highest in South Asians. Are you surprised? I'm not surprised, because GDM always we had the highest prevalence. So Southeast Asians, South Asians seem to have the highest prevalence. Of course, late GDM is also we are the highest, okay? So we can't say it's not relevant to us. If at all, it's more relevant to us than to other populations, okay? Now, why are they getting early GDM? We're doing a number of studies on this, but I'm just showing you some published studies. This is not our study. 2 studies back to back in diabetes care looked at this, where they looked at insulin secretion, they looked at insulin resistance. Which is more? Why are they getting it at an early age? Very clearly, the results seem to show, if you look at late GDM, these are different methods of measuring pancreatic beta cell function. Measure insulin, C-peptide, insulin secretion rate, anything you can measure, beta cell function. Whatever you measure, the early GDMs have lower beta cell function. They don't have enough insulin secretion. That is why they're developing it early compared to the late GDM. The late GDM is a little better beta cell function. They can go up to 24, 28 weeks, then only they're getting it. Here, they're getting it early because the beta cells are weaker. That is why they're converting faster to diabetes. Now, everything like a jigsaw puzzle, everything is fitting in. So now, we have a completely different paradigm. Until about a year ago, or 2 years ago, screening for GDM was always in the second trimester. Of course, from 2006, DIPSI, Professor Sheshaya had been suggesting that early in pregnancy, first trimester, at booking itself, you should screen. And that's very true, because in India, when you have 25-30%, it has to be done. But mostly, it was for picking up diabetes, pre-existing. We don't want them to go on till end of pregnancy without knowing it. Now, from the whole world, not just for Indians, not just type 1 and type 2 to be diagnosed in first trimester, but early GDM also to be picked up. So early GDM also is picked up, late GDM also has to be picked up. There are a lot of unanswered questions. If you don't have early GDM, should you still screen for late GDM? Which test should you do? Should you do GTT here, GTT there? Should you do fasting here, fasting there? Should you do HbA1c here, HbA1c there? Should you do a combination of both? All these need more studies, and such studies are going on. The moment the toboggan was studied, the world started waking up, and the first to respond was Belgium. So the Flemish consensus was developed, where they clearly say screen in the first trimester of pregnancy. They were the first to say it for early GDM. And what do? They use the higher cut point, 95. You can see the higher cut point. So they said the higher band glucose is what toboggan showed. Let's use that. Let's not screen at the lower level. So they are very good in that. Australia soon followed, and the Australasian Diabetes Society has recommended this. Russia has followed now, and a few other countries are now writing their guidelines. I expect that within 1 or 2 years, everybody will be following this, because early GDM is now getting accepted. So I'd like to conclude, ladies and gentlemen, by saying that GDM is now rapidly rising, and Wing study showed that if you really diagnose and treat GDM, you can get results just like non-GDM women. Early pregnancy screening is very essential to diagnose early GDM. Early GDM has more severe insulin secretory defect. Toboggan study showed that it's beneficial to treat. There are no side effects. The higher band of early for diagnosing early GDM, that is 95 and above, seems to be more relevant. It's cost effective. We have the highest prevalence of eGDM probably in the whole world, and many countries have already started accepting eGDM screening, and others should soon follow. So my one concluding message is early GDM must be identified and treated. That one message you can get, forget about all other things I said. Look for GDM also in the first trimester. Use any criteria you want, I don't bother, but look for it. Those are my contact details in case you want to, and that's my WhatsApp channel. if you want to join it. Thank you very much.